Also, we have some case report even inside the heart with some difficulties in cannulation of coronary sinus uh, because of a small heart, and sometimes the ostium axis is different from the other, become higher or sometimes more perpendicular. So we needed another axis like subclavian, left subclavian to be more easier to cannulate coronary sinus. And in another paper, which is regarding patients less than 18 months old, we found that there is no any difference according to acute complication in the venous system regarding the weight, even success rate, especially in excessive busway, because this paper was most or more regarding excessive busway mainly. So we don't find also no difference between success rate and the weight of the patient. And we found here is higher success rate regarding excessive busway, even RT, atrial tachycardia, even ectopic, but maybe have some difficulties or maybe less success rate regarding VT and atrial flutter. So we have some precaution during ventricular vascular access in pediatric, like using soft guide wires and also contrast injection to know because some we can say some congenital anomalies in pediatric and more collaterals than adult. So we have some contrast injection. We have any difficulties in progressing our catheter. And also, if you have some perforation during placing of cheeses or catheter, the perforated cheese or catheter shouldn't be removed, but kept in situ till we have surgical or vascular consultation. Also, in some cases, if you have SVC or IVC dissection, large vascular dissection, we should using balloon, angioplasty balloon for tamponamine of major vessels. Also, we have some attention should be given to manipulating catheter on free wall of right ventricle, anterior wall of RVT, and the roof of left atrium, because these areas are busty or busty of musculature, making perforation is high risk even with a small contact force. The tip all the time should be watched carefully, all the movement during the heart. And if we can have some technology like stereotaxis, because stereotaxis, as we know, that it's a very flexible one, and there is no any complication regarding the perforation regarding the stereotaxis catheter. From our experience, also we showed using contact force catheters and impedance stroke curve during manipulation inside the heart of the pediatrics. We can summarize the complication regarding vascular access. We showed using vascular anatomy, various contrast and duplex, and not push at all inside the vascular access to the heart. And we don't pushing if we have no the access of the vascular or doing it blindly. Avoid the collateral damage. The collateral damage inside the heart is very common because of the small size of the heart and even relatively proximity of the compact AV node to the posterior septal region, smaller conosinus, smaller subocean isthmus. So AV nodal damage is very common inside the regarding the pediatric. Also, if you have some ablation outside I can solve. There is a problem to repeat something. It's okay to
We hear you good, but there are some noise outside you. So Ali, please mute any microphone. Go ahead, Ahmed.
Okay, Dr. Merva. Another example of collateral damage during left atrial ablation, like atrial flutters and atrial tachycardia, we can damage the esophagus or arterial system or pulmonary veins itself. Also, from during ablation of left side accessory busway and RVOT, we can damage left main coronary artery. And the conduction system also, which as we said before, we can use in cryoablation, use mapping system -35 and Berman lesion -75 to -80. So we can using mapping, cryo mapping before ablation. If you have like anteroseptal accessory busway or even RT in some cases, if you have small size heart in pediatrics. Also, we can using 3-dimension mapping system to do his cloud before going to ablation. And this is table showing the most common arrhythmias that we can have epineudal compact damage, like epineudal re-entry, mid-septal accessible busway, anteroseptal accessible busway, crested terminalis tachycardia, and sinus node. This one from sinus node, aortic cusp tachycardia, and compact evinode also from non-coronary cusp, vesicular tachycardia, and infrahissing conduction system, especially in patients with right bundle branch block. From the arterial damage, from this image, we can see how the proximity of right coronary artery, this one, and the tricuspid annulus. So any mapping, any ablation trials according to tricuspid annulus in the pediatric, we can damage or collateral damage of right coronary artery. And for accessible sway in around the mitral annulus, we see here the circumflex proximity to the mitral annulus, and we can also damage the LCX in anywhere in along the mitral annulus. Another collateral damage that we can have during ablation of left atrium, beside arterial damage, we can have pulmonary vein stenosis, coronary artery damage, pulmonary artery damage to the aorta, esophagus, phrenic nerve, mitral valve, thrombus formation, or autonomic nerve damage because the proximity of ganglion plexus to the left atrium, and also the very thin muscular tissue of the pediatric left atrium. When we have mitral annular tachycardia, also during non-coronary cusp tachycardia or automatic atrial tachycardia from anterior mitral annulus, we should have dilated, detailed 3D mapping. Coronary angiogram is also very important, and the treated RF energy during ablation. And we should be away 5 to 10 milli from the nearest coronary artery. Also during ablation of mitral isthmus, during ablation of left atrial flutter and congenital heart disease or repaired post-surgical repair of some pediatric patient, because of this relative thickness of myocardium at this site. So most of ablation physician just don't do more temperature, more contact at this area. So we should, in this area, we have some precaution, like just ablation, just till we have diminished of local electrogram, so we should be signal guided, or some fragmentation which is an indication from the isolation at this area. And also when ablating just near to the vein of Marshall, as we see here, we should be atrialized to coronary sinus, because the ventricular part of coronary sinus is related to the left circumflex. So we should have REO. So in many pediatric center, we should have biplane fluoroscopy to see the both image at the same time, to be atrialized the coronary sinus, to be away from the LCX, and from LEO to be in the correct site. Also, coronary sinus isolation or ostial ablation for the cases of post-receptal accessible busway, because this relation to middle cardiac vein, and sometimes we need to go inside the coronary sinus, or to be inside the middle cardiac vein, or be in deep in the pouch. Should we take care from these cases because of damage of the posterior descending artery, and sometimes branches from right coronary artery, and sometimes we have evinodal block at this side because of the evinodal artery which is coming from right coronary artery. So also we need to have coronary angiogram to be away more than 5 millimeter from the coronary angiogram. And if we have some favorable site of ablation, and this site is near to coronary artery, so we should have IVUS just placed in the coronary artery during the ablation to see any signal of starting of arterial damage. And also sometimes we can use cryoenergy to be away from the coronary artery. Also the esophagus and the vagus nerve damage during ablation at the posterior left atrium in cases of atypical atrial flutter, or sometimes actually in the pediatric resistant atrial fibrillation ablation is very less common, but sometimes we need it. So we should be away from pulmonary vein ostium, from BV stenosis, to be 5 millimeter atrial to the ostium of the vein, also using ice, and sometimes using real-time CT scanning and using electrophysiological maneuver. Electrosurgical maneuver, it's like using signal guiding or impedance guiding to be away from pulmonary vein ostium. Also, during ablation of posterior accessory pathway, we have the same problem. Sometimes we have thermal damage to esophagus or vagus nerve, so we should be also using our precaution. We have some clinical signs of patient just after ablation, and it's an early indications that we have esophageal fistula formation or vagal nerve injury. In esophageal fistula formation, we find dysphagia, adenophagia, stroke because of air embolism, endocarditis, or air in left atrium on echocardiography, or sepsis because of GIT flora, because the pressure in esophagus will be more than left atrium. So we have GI flora coming from GIT and going to left atrium. You have endocarditis. Vagal nerve injury like bloating, pyloric spasm, massive stomach enlargement, or some laboratory evidence of gastroparesis. Using of ice is very important during ablation of left atrium in some children when they are very low weight. Because of visualization of catheter position, all the procedure, and also we should have visualization for esophagus, like in this image, the esophagus and oblique sinus, because the oblique sinus and the pericardium will be the first areas that be filled with effusion if we have early signs of effusion. It will be increased echogenicity or some effusion. We will see it and should be stopping ablation on this side. So is what I said now is about all procedure related to ablation communication. I could proceed if you have any question now before proceeding to pacemaker implantation. Okay, to proceed. Okay. Actually, for a very operative complication of pacemaker and ICD implantation, according to the guidelines, we have all of them are less frequent, but we have more frequent with the epicardial effusion. It's 10.2%, and also pocket hematoma. It's about 16% of cases. Still, to 16% of cases, we can have pocket hematoma and its consequences like pocket infection after that. We'll start with perforation because it's most common. We have about 1.5% of patients we have perforation. We have two actually acute. It's less than 24 hours, and subacute it's during 1 month of 1 month from the procedure, and it's very rare to see it later, like 1 year or something like that. We have some consequences of lead perforation, or these signs can give us like indication or signs for epicardial perforation, like acute pericarditis, pericardial effusion, tamponade as acute consequences, or later like the pragmatic stimulation or abnormal electrical parameters. Tamponade, which was of sequences of bleed perforation, we can see it as a first as hemodynamic instability. And actually, during lead implantation, we have hemodynamic instability. We have some differential diagnosis like vagal reaction. And if there's no vagal reaction, I can see the fluoroscopy to see the cardiac silhouette is immobile or something like that. I can use the echo, and we can see here how the cardiac effusion is very significant in this case. Also, tamponade can be confirmed as echo, and also most of cases asymptomatic. We can see effusion just after implantation, and it can be unnoticed in most of cases. Management, according to the case, if you have hemodynamically unstable and large effusion, we can just do pericardiocentesis. In some cases, we can say it's consideration or considered to do pericardiocentesis, even we have just moderate effusion if the patient will require antiplatelet drugs or anticoagulation, so we can proceed to pericardiocentesis even with moderate effusion, or we have with even mild or moderate effusion, I have hemodynamic instability. We have some factors that affecting or we can estimate that I have lead perforation, like elderly age, like female gender, body mass index, and it's very important for pediatric because all of them are thin and our body mass index are less than 20. Also, if we have left 100 branch block before prior to heart failure, so using antiplatelet agent, or if the patient has temporal pacing before going to permanent lead implantation. Also, small diameters or ICD leads also for pediatric. Also ICD leads is more common using active fixation lead or lateral atrial lead, apical right ventricular lead also, because now in the guidelines it's not recommended to have apical right ventricular lead. Actually, here we in this paper they comparing between active fixation lead and passive fixation lead, and there is no any difference between them regarding the fusion or perforation. So no problem to using active or passive lead fixation. Also look at hematoma, because as we said, it's about 16% depending on definition of factors, and also create 9-fold increases confection. It's one of independent factor for increases of infection. So we have some precaution. If you have buccal hematoma, needle aspiration is contraindicated in all guidelines to do. We should using during the procedure, if the patient I know that he has antiplatelet or anticoagulation prior or post procedure, I should go surgical technique to with minimum tissue trauma, hemostatic resorbable suture may be placed at venous entry sites, or compression using sandbags or taps and vessels can be useful to avoid hematoma. Actually, we have infection in the chronic do is one is very recent paper about the pacemaker infection, especially or cardiac devices infection. As first, we have some prevention, as we said before. It's like antimicrobial invade from the first. If I know this patient has high infection rate, hematoma prevention, single dose preoperative simazoline. Actually, the local antibiotic is not recommended now in guidelines. So I'm using this just simazoline is systemic antibiotic just before the procedure or pre-procedure within 2 to 6 hours before the procedure. And if I have diagnosis by labs or CT scan or transvaginal echo, so I'm going to the management. I can do removal, complete removal, or using antimicrobial suppression, or using a new CID implementation once a bucket adequately debrided and in blood culture are negative. And also in some patients with ICT, I can go into SICD if I have high risk infection patient in pediatric. Lead dislodgement, it's about 3% of implantation. It's more higher for atrial lead because of appendage and the contractility of the appendage, and also the small one. Actually, I have also two forms of lead dislodgement. A large one, which can be seen in chest X-ray, and another one, which is micro dislodgement, and it's very difficult to diagnose it by just X-ray, and we can using electric testing that like high threshold after fixation. If dislodgement is not, I mean, is not affecting the lead and not affecting the threshold, I can postpone as I can. I mean, it's not mandatory to go inside and repositioning is necessary. If I can postpone as I can in lead dislodgement. Of course, this one is macro dislodgement of the lead. It's going down, and all the pocket is going down. So it's recommended also in guidelines that the battery is sutured well in the pocket, not to move, especially into ICD. Pneumothorax also, it's about 0.4% and about 2.8%, and it's dependent on venous access. So now it's recommended using cephalic cut down and also using axillary vein puncture and going away from subclavian to go rid of this complication, using fluoroscopy after implantation of pacemaker is recommended for all patients within 24 hours. And sometimes we can using CT scan if I just estimated this complication, but I don't found anything on X-ray, so I can using CT scan for the patient also. Sometimes pneumothorax is very small, so just conservative management, and sometimes in female also sex, low BMI for pediatrics also. If we have chronic obstructive pulmonary disease, sometimes we do pleural chest tube to get away from this complication. And then we can see here how this lung is compressed by pneumothorax, and the heavy one is more than 2 fingers. So I think this patient will go into chest tube. Also, one of common one, I think it's not common in pediatric, but also we can see it sometimes. It's shoulder pain or shoulder freezing just after implantation, and we can find here it's an interesting paper, and they recommended in this paper to using exercise to do some exercise just after device implantation and not using arm sling. And we find this paper that if using exercise, we can decreasing the chest, shoulder pain and shoulder freezing. Exercise actually is very nice, but I don't use it before. I don't know if anyone has this experience before to recommend this exercise for the patient just after implantation. Actually, I will be afraid to do that, but it's recommended in papers and literature. At the end, post-operative management for all patients after implantation, we should using chest X-ray, 12 lead. Patients should be mobilized freely, as we said in last paper. No evidence that limitation of arm movement after implantation will avoid dislodgement, and also it will increasing the shoulder freezing and shoulder pain. Using arm slings should be avoided. Wound also should be covered by dressing about 2 to 10 days. If your patient needs shower, we should using waterproof dressing, and also after within 1 week or moist towel in the meantime to the upper body away from the wound. Routine wound inspection is not superior to patient-initiated consultation. It means the patient should he can cover 2 to 10 days the wound without any inspection, and the first consultation should be within 1 to 3 months just after implantation. Many thanks.
Thank you so much for that very interesting presentation. You raised so many interesting points, and I agree. You pulled out some interesting papers and addressed that topic so nicely. Thank you for that very interesting presentation. I hope that the listeners are not feeling too nervous about the complication rate in children. Actually, in pediatric procedures, the patients are not that delicate. They're actually quite resistant. But you made some really nice points. I would just make one small comment, but I do want to hear if others have comments. I liked the paper that you showed on the exercises after device implant. I think that we have a tendency to restrict arm movement too much after devices. I place them as you do, probably in young patients sometimes, and they do not limit their activity at all, and they rarely dislodge the lead. So I think we can allow our patients to move their arms more freely, and that we should not be requiring a sling. Very rare to have a dislodgement after the first day. But anyway, please, are there any comments, or I would love to hear any questions people have, but also if there are any recent complications that you would like to discuss, I'd be very happy for us all to hear about them.
Okay, Dr. David, thank you. Thank you, Dr. David.
Yes, I do have some questions to Dr. Ahmed Mustafa. Very nice presentation. David Ahmed is running both hospitals, the adult in Cairo University, which is the biggest and most ancient university in Egypt, and also the pediatric hospital, which is called Abu Rish. And he is doing a great job building up the system of pediatric electrophysiologists, helping Daina and Dr. Osama, who presented with us. Ahmed is supporting this team to be the best in Egypt.
Thank you, Dr.
Ahmed, I had a patient who underwent dual chamber pacemaker at Ain Shams University after post-Fallot complete heart block. We didn't know if it was congenital before the procedure or post-surgical. He was non-complex, and it was like sometimes conducting 1:1 to 1:30, 1:40. After 4 years of implantation, the ventricular lead perforated the right ventricle. And Dr. Hala Mursafahi was her patient from Mansoura, and she did him a very good test, which is Holter monitor. After I stopped the device, I stopped the device because it was functionless. So he was followed up with me directly, and every measurement was perfect until 4 years. Then I found that the lead was perforating the right ventricle, no effusion. So we had a big session at Mansoura Pediatric Hospital to extract both leads, the atrial and the ventricular lead. And it was very difficult. Although it was only 4 years, but it was really very, very difficult. We had to use the evolution, we had to use the looking stylets, and we had to use the liberating sheath, the call it telescopic sheath, in order to take it out. Why did it happen after 4 years?
Actually, to Mehmet, according to literature, we have what's called as later perforation, and maybe this lead is perforated actually, and sometimes it's mini dislodgement. I mean, this the reading for you. It's extreme from the first reading or just near. I mean, it's the threshold is becoming like 2 or 3 or it's become extreme. I mean, I need for 4 threshold or 5 threshold to have capturing.
It was less than 1. And then it became no capture. I thought, what happened?
No capture at all, yes?
At all. Unipolar, bipolar. The impedance were normal. There was no change in impedance. There was no lead fracture. There was no insulation break, but there was perforation. We had an X-ray lateral view, and we saw the lead is behind the sternum. Was it perforating before, and then it kept in growing? What yani? I don't know why it happened.
Do you know if I think Dr. Rodina said it in her lecture about the implantation, because in pediatric we like to do like this alpha loop because when the patient is become longer and the heart is become larger, it just withdrawing or just the pressure will be on the loop, not on the tip of the lead itself. So I think if I don't know you do alpha loop before or not, but it's alpha loop.
I used to do it before.
And this patient,
and then in this patient was not a loop. There was no a loop. There was not a loop.
Yeah, because as you said to Mervat, maybe with the heart become longer and larger, we have some pressure on the tip in this area, which is become fibrosed or something like that, and it will be easy to perforate at this area. So alpha loop it's recommended in pediatric to make the pressure on the loop, not on the tip itself.
Okay, thank you, Ahmed. Next question was regarding the movements which you showed us. For me, I cannot do this, as you said, because they will dislodge the lead definitely.
Yeah. Actually, for me also, I'm happy to do that, but it's literature recommendation. I'm just present it for all, just to know it. But
so I will give you a different opinion though. I when you put a device in a 6-year-old child and he goes home after on post-op day 3, he will play with his brother and he will jump off the furniture and he will run around and he will fall over and he never dislodges the lead. So I want you to feel more confidence. If you have enough slack in the lead, it's a very small movement that happens with our movement. Remember, it's just from the clavicle to the right ventricle that you have your lead. All those other movements are external to that. So I feel that we can be more generous. Sometimes larger patients say that their shoulder is so painful after they have been restricted, and I want you to feel confident that your leads will stay where they are.
Okay. Thank you.
So are there any? I would love to hear, if we have just a few minutes, if there are any questions, I would be very happy to discuss with everybody.